Welcome to this e-course on the integrated management of HIV and non-communicable diseases. NCDs include hypertension, cardiovascular disease, renal disease, cancer, chronic respiratory disease, diabetes, and mental health disorders. This module contains audio. Please adjust your speaker settings as necessary. You may activate the audio presentation of each slide by clicking on the audio icon, located in the bottom left or bottom right corner on each slide. To advance from one slide to the next, click on the right arrow if in slideshow mode. Alternatively, you may be able to use the page down function or simply to click open the desired slide. The primary sources of evidence used in the preparation of this training are guidelines produced by the World Health Organization for the management of non-communicable disease in settings with limited resources. For the most part, these WHO guidelines are not contextualized for people living with HIV. Exceptions are the WHO Consolidated Guidelines on the use of antiretroviral drugs for treating and preventing HIV infection, which provide some guidance on HIV and NCDs, and the WHO Guidelines for the Screening and Control of Cervical Cancer, which provide specific guidance for women and adolescent girls with HIV. Many countries have national clinical guidelines on the management of NCDs, and some countries, such as Kenya, have incorporated recommendations on the pharmacological and non-pharmacological management of NCDs into their national HIV guidelines. It is recommended that you view this training module in the context of your national guidelines. A complete list of the documents used in the preparation of this training can be found on the final slide. The WHO estimates that NCDs kill 38 million people each year globally. The vast majority of premature deaths from NCDs, that is deaths before 70 years of age, occur in low and middle-income countries. 4 groups of diseases together account for 82% of annual NCD deaths. These are cardiovascular diseases, cancers, respiratory diseases, and diabetes. As a result of prolonged survival, people with HIV now live long enough to become as susceptible as HIV-negative subjects to the diseases of aging. It is equally likely that HIV infection itself, as well as long-term HIV treatment, create an excess risk for certain NCDs. There is a complex web of causation that includes advancing age, infectious comorbidities such as viral hepatitis, HIV infection itself, the complications of antiretroviral therapy, and lifestyle risk factors that increase the risk of dying from the non-communicable disease. Although traditional risk factors for cardiovascular disease, diabetes, hypertension, hyperlipidemia, and smoking exist in people with HIV, evidence from epidemiological studies suggests that there is an increased risk for cardiovascular disease even after controlling for these factors. Indeed, cardiovascular disease is now one of the leading causes of non-age-related morbidity and mortality in people living with HIV. The importance of integrating HIV and NCD services in low and middle-income settings. There is often limited access to NCD care and treatment in these countries, with inadequate guidance and provider training, particularly at the primary care level, as well as a lack of essential diagnostics and medications to treat NCDs. PEPFAR has called for the integration of HIV treatment and NCD services in a health-centered and wellness approach, where people with HIV benefit from medical care that goes beyond HIV alone. Opportunities for integration ought to leverage the widespread introduction of differentiated service delivery models, in which people with HIV can be followed with fewer health facility visits, potentially decongesting clinics, and allowing more time for the management of more complex health issues. This training module covers a selection of common non-communicable disease conditions: hypertension and cardiovascular disease, diabetes, depression, asthma and chronic obstructive pulmonary disease, and cervical cancer. While cervical cancer is caused by human papillomavirus and therefore has an infectious cause, cervical cancer is included in NCD guidelines produced by the WHO and is a program priority for PEPFAR in terms of HIV and NCD integration. Cervical cancer is included here owing to the significant morbidity and mortality that is associated with cervical cancer in women and adolescent girls living with HIV, and due to the critical need to link HIV services with cervical cancer screening programs. All medicines mentioned in this module are entered in the WHO Model Essential Medicines list. The essential technologies cited are listed in the WHO Prevention and Control of Non-Communicable Diseases guidelines for primary healthcare in low-resource settings. Typically, there are national adaptations of WHO guidelines, and there may be minor variations from the Model Essential Medicines and Diagnostics list. Please refer to your national adaptations for more details. This slide summarizes the recommendations on screening and management of NCDs included in WHO 2016 Guidelines on the Use of Antiretroviral Drugs for Treating and Preventing HIV Infection. The guidelines recommend that assessment and management of cardiovascular risk should be provided for all individuals living with HIV according to standard protocols recommended for the general population. Take a moment to review this table and what WHO recommends at the time of HIV diagnosis and enrollment into care, at the time of ART initiation for those receiving ART, and at the time of suspected treatment failure. The key recommended assessments include screening and management of mental health problems and substance use, nutritional assessment and counseling, and screening for cervical cancer. Hypertension and HIV. The data in this slide are obtained from the East African Chronic Diseases Research Project, which was a population survey among adults in 4 districts and 80 primary care facilities in Uganda and Tanzania. Prevalence of hypertension among adults with HIV was 15 to 18%. Diabetes, on the other hand, was infrequently diagnosed. Adults on ART have a higher prevalence of hypertension compared with HIV uninfected individuals. Screening for hypertension should therefore form part of the regular assessment in HIV care, with a blood pressure measurement at HIV diagnosis before beginning antiretroviral therapy and at least every year after that. The clinical management of hypertension in the context of HIV is similar to that of the general population, with particular attention needed towards clinically important drug interactions between antihypertensives and antiretrovirals. All people with HIV need to be screened for other risk factors for hypertension, which include tobacco smoking, diabetes, obesity, sedentary lifestyle, an unhealthy diet, family history of hypertension, and older age. If risk factors are identified, lifestyle modifications should be advised. Lifestyle modifications are the first step in prevention and control of hypertension and other cardiovascular diseases. Health education and counseling on healthy behaviors should always be integrated into routine HIV care and treatment. WHO recommends moderate levels of physical activity, such as walking 150 minutes per week, and reducing and controlling body weight. Non-smokers should be encouraged not to start smoking, and people who are smoking strongly advised to quit and supported in their efforts to do so. The basic recommendation for a heart-healthy diet is restricting salt to less than 1 teaspoon per day, limiting fatty food, and eating a diet high in fruits and vegetables. Guidance on avoiding harmful use of alcohol is illustrated in this slide. The Centers for Disease Control recommends that men should drink no more than 4 alcoholic drinks on any day, and no more than 14 per week, while women should drink no more than 3 drinks per day, and no more than 7 drinks per week. Treatment for uncomplicated hypertension, irrespective of HIV status, is either mono or combination therapy with a low-dose thiazide diuretic, 12.5 hydrochlorothiazide or equivalent, a calcium channel blocker, an angiotensin-converting enzyme inhibitor, an angiotensin receptor blocker, or a beta blocker. These different classes of antihypertensives produce similar reductions in blood pressure, can be combined, and their antihypertensive effect is additive. Introduce one drug at a time, starting at the lowest dose, and allow 2 to 3 weeks to achieve maximal effect before titrating the dosage upwards. Titrate to maximum dosage before adding another drug. If the response is inadequate after titrating to a maximum dose, the goal is a BP less than 140/90. Add a second drug, starting at the lowest dose, and titrate again to the maximum dose. Fixed dose combinations improve adherence. If there is inadequate response to two agents, consider consultation with or referral to a provider experienced in the management of refractory hypertension. Always evaluate and control cardiovascular risk factors and provide patient education and advice on lifestyle modification. There are no interactions between thiazide diuretics and ACE inhibitors and ARVs. Drug levels of some calcium channel blockers and beta blockers are increased in the presence of some protease inhibitors and decreased in the presence of some NNRTIs. Dose adjustment of the antihypertensive agent may be required as illustrated in this slide. However, drug levels of ARVs are not affected by calcium channel blockers or beta blockers, and no dose adjustment for the ARVs is required. Exercise caution when co-administering beta blockers and protease inhibitors due to prolongation of the QT interval. ECG monitoring is advised. Who needs consultation with or referral to an experienced provider? Patients with severe hypertension should be managed at the appropriate level of care and caregiver in accordance with local resources. Patients with blood pressure not at goal following the initiation and dose increases of two antihypertensive medications to the maximum recommended dose should be referred to a provider experienced in the management of refractory hypertension. Blood pressure greater than 180/120 with evidence of target organ damage, such as encephalopathy, stroke, myocardial infarction, acute left ventricular failure, or pulmonary edema, unstable angina, preeclampsia, and eclampsia of pregnancy are indications for immediate referral to an experienced provider. Type 2 diabetes and HIV. The prevalence of diabetes in people living with HIV has been reported as 2 to 14%, with data coming from European, North American, and African cohorts. There is conflicting evidence on whether HIV is an independent risk factor for diabetes. Some studies report an increased risk of diabetes in people living with HIV, and some show no association. The data in this slide were presented at the AIDS 2018 conference in Amsterdam. The studies summarized here support the notion that prevalence of type 2 diabetes does not seem to be increased in people living with HIV. Symptoms of diabetes include unusual thirst, frequent urination, unusual hunger, weight loss or weight gain, extreme fatigue, frequent infections, blurred vision, tingling or numbness in the hands and feet, and slow healing of cuts or bruises. However, people with type 2 diabetes may have no symptoms for many years. WHO has provided guidelines for the integration of the management of type 2 diabetes into primary health care settings. The International Diabetes Federation Global Guideline for Type 2 Diabetes provides guidance stratified according to 3 levels of care. 1. Standard of care. 2. Care limited by resource constraints. 3. Comprehensive and complete range of healthcare technologies. Neither of these guidelines are HIV-specific, but the 2017 Guideline for the Management of Type 2 Diabetes from the Society of Endocrinology, Metabolism and Diabetes of South Africa, SEMSTA, contains a chapter dedicated to HIV and diabetes. Criteria for the diagnosis of diabetes in HIV-infected individuals are the same as the general population, with one caveat. It has been reported that HbA1c levels underestimate glycemia by 10 to 15% in HIV-infected persons. The HbA1c test measures the amount of glucose attached to hemoglobin and is used to assess long-term blood glucose control. The following are WHO-recommended criteria for diagnosis of diabetes. Fasting plasma glucose level greater than or equal to 7 millimoles per liter, or 126 milligrams per deciliter. Random plasma glucose greater than or equal to 11.1 millimoles per liter, or 200 milligrams per deciliter in the presence of classical symptoms of diabetes. Plasma glucose greater than or equal to 11.1 millimoles per liter 2 hours after ingestion of a 75-gram oral glucose load during an oral glucose tolerance test. Diabetes can also be diagnosed by a HbA1c level greater than or equal to 6.5%. Fasting capillary glucose from a finger prick sample is likely to be the most feasible measurement in low-resource settings. Fasting glucose values for venous and capillary plasma are identical. Point-of-care blood glucose meters can be used in diagnosing diabetes if laboratory services are not available. The International Diabetes Federation Global Guidance for Type 2 Diabetes recommends that visually read glucose test strips have a role in limited care situations where blood glucose meters are not available. The IDF further recommends that if blood glucose testing is not available in limited care settings, the presence of glucose in urine, especially when combined with classical symptoms of diabetes, may be used to diagnose diabetes. Screening to detect type 2 diabetes and to assess future risk of diabetes is the same for those with and without HIV infection, with the exception of the caveat around the use of HbA1c. Screening should be considered in adults of any age who are overweight or obese, indicated by a BMI greater than or equal to 25 kilograms per square meter, and who have one or more of the additional risk factors for diabetes: physical inactivity, family history, high-risk ethnicity, women with a history of gestational diabetes or the delivery of a baby weighing more than 4 kilograms. In the absence of risk factors, screening for diabetes is recommended from 45 years of age. People with HIV should be screened at HIV diagnosis or before initiating ART, and annually after that if initial screening was normal. Generally, people with type 1 diabetes present with acute symptoms of diabetes and markedly elevated blood glucose levels, and most cases are diagnosed soon after the onset of hyperglycemia. If glucose control is not achieved with the lifestyle modifications alone, treatment with oral hypoglycemic drugs should be initiated. Biguanides and sulfonylureas are recommended by WHO in resource-limited settings. Metformin should be used with caution in HIV patients with renal insufficiency, liver disease, active infection including tuberculosis, and those with severe wasting or congestive cardiac failure, owing to the risk of lactic acidosis induced by metformin. Caution should be exercised when metformin is co-administered with dolutegravir. Metformin should be discontinued during acute severe illness such as pneumonia or other severe infection, dehydration, or myocardial infarction. The starting dose of metformin is 500 milligrams once daily, given with a meal, breakfast or dinner. Dosage increases should be made in increments of 500 milligrams weekly every 2 weeks to achieve the target plasma glucose level of less than 7 millimoles per liter, 126 milligrams per deciliter, or until side effects lead the interruption of therapy, up to a maximum of 1,000 milligrams twice daily. Responses are generally not seen at doses below 1,500 milligrams per day. A longer-acting formulation that can be given once daily is available in some countries. Sulfonylureas should be prescribed to individuals who have contraindications to metformin, or in whom metformin does not improve glycemic control at the maximum tolerated metformin dose. Glibenclamide is a second-generation sulfonylurea, and the only sulfonylurea on the 2017 WHO Essential Medicines list. It is most likely to be available in low-resource settings. As a precaution, glibenclamide should be started at a low dose of 2.5 to 5 milligrams once daily with breakfast, and adjusted according to response to a maximum dose of 15 milligrams daily. The Society for Endocrinology, Metabolism and Diabetes of South Africa, SEMSDA, recommends that glibenclamide should not be used at the primary care level and advises modified-release gliclazide, because it has equivalent efficacy, is consistently associated with lower rates of hypoglycemia, and has better cardiovascular and renal safety relative to other sulfonylureas. Co-administration of metformin with dolutegravir significantly increases metformin blood levels. Dose adjustment of metformin should therefore be considered when co-administering dolutegravir with metformin. U.S. prescribing information recommends limiting the total daily dose of metformin to 1,000 milligrams and monitoring renal function and blood glucose levels when co-administering metformin and dolutegravir. Because metformin is eliminated by the kidney, patients with moderate renal impairment may be at an increased risk for lactic acidosis due to increased metformin concentrations. There are no drug interactions between oral hypoglycemic agents and tenofovir, AZT, 3TC, or FTC. There are potential interactions with NNRTI and protease inhibitor antiretroviral drugs, resulting in increased or decreased levels of the sulfonylurea, which may require dose adjustment of the sulfonylurea. Glucose should be monitored and the dose of sulfonylurea adjusted as needed. We have already mentioned that caution needs to be exercised if co-administering metformin with dolutegravir, as metformin levels are increased and a dose reduction of metformin may be required. This next section focuses on depression and HIV. The 2016 WHO Consolidated ART Guidelines recommend that assessment and management of depression should be included in the package of HIV care services for all individuals living with HIV. Depression is 2 to 3 times more prevalent in people with HIV than in the general population. In both well-resourced and resource-limited settings, depression is a significant contributing factor to poor adherence to ART and poor HIV treatment outcomes, including treatment failure. The World Health Organization has identified mental health assessment and treatment as an essential care intervention for those living with HIV in resource-limited settings. Both psychotherapy and antidepressant medications, or a combination of the two, have demonstrated benefit in alleviating the symptoms of depression in people with HIV. Efavirenz is a component of first-line antiretroviral therapy in current WHO HIV treatment guidelines. Central nervous system, or CNS, side effects of efavirenz are common, but generally mild and transient. They include dizziness, irritability, headache, diminished concentration, euphoria, vertigo, dreams and nightmares, and depression. The incidence of efavirenz-associated CNS side effects has been reported as 40 to 60%. Dosing efavirenz on an empty stomach as well as at bedtime improves tolerability. Approximately 2% of subjects, however, report more serious neurological effects, including delusion, paranoia, depersonalization, hallucinations, anxiety, mania, and severe depression. The majority of efavirenz-induced CNS effects appear early and can appear as early as after the first dose and resolve within 1 month. In some cases, they can persist for months or not resolve at all. It is important to explain the side effects and their usual mild and transient nature to people before they start efavirenz. People with HIV who have pre-existing depression and those who have prolonged depressive symptoms after initiating efavirenz should be prescribed an alternative antiretroviral drug such as dolutegravir, nevirapine, or a protease inhibitor, depending on availability. Several tools are available to facilitate screening for depression. The Patient Health Questionnaire 9, PHQ-9, is a self-administered diagnostic instrument that has been shown to be a reliable and valid tool in making a symptom-based diagnosis of depression and measuring the severity of depression. It has been utilized in the screening for depression in people living with HIV in both well-resourced and resource-limited settings. This table summarizes how to interpret the PHQ-9 score and suggested management. A score of less than 5 indicates depression is unlikely and screening should be repeated as needed. A score of 5 to 10 indicates mild depression, and a score greater than 10 indicates moderate or severe depression. Mild depression can be managed with psychological counseling and support. For moderate or severe depression, antidepressant medication may be considered. If you are unfamiliar with the use of antidepressants, you should consult with or refer to an experienced provider. Bipolar disorder, also known as manic depressive illness, is a disorder characterized by mania, unusual shifts in mood, energy, activity levels, and the ability to carry out day-to-day tasks. Mania is marked by increased activity levels, trouble sleeping, talking fast about a lot of different things, and doing risky things like spending a lot of money or having reckless sex. Bipolar disorder is associated with increased HIV transmission risk behavior among people with HIV. A careful medical history is needed to ensure that bipolar disorder is not mistakenly diagnosed as depression. Medications used to treat bipolar disorder include mood stabilizers, antipsychotics, and antidepressants. The PHQ-9 tool forms only a part of a complete assessment for depression. A full medical history, physical examination, and a mental health status assessment are also essential in persons in whom depression is suspected. Depressive symptoms can be confused with those of other medical illnesses that can be detected by physical examination. For example, weight loss and fatigue may be associated with diabetes, cancer, or thyroid disease. Depressive symptoms can equally be confused with normal distress following severe stress. For example, domestic violence, death of a loved one, disaster, as revealed by history taking. Please take a moment to review this table, which summarizes how to conduct a mental health status assessment. Here is another table, this time summarizing non-pharmacological management steps for depression. These steps are psychosocial support and education, reducing stress and strengthening social support, and the promotion of functioning in normal daily activities. Please take a moment to read the key messages under each step. There are two main classes of antidepressant drugs: tricyclic antidepressants and selective serotonin reuptake inhibitors, or SSRIs. Two antidepressants are on the WHO Essential Medicines list: amitriptyline and fluoxetine. Both are pregnancy classification C, meaning there is insufficient evidence to gauge their safety in pregnancy. The advice of a specialist familiar with alternatives should be sought where possible. Dosing for amitriptyline is started at 25 mg at bedtime, increasing by 25 to 50 mg per week to a maximum of 150 mg per day. The minimum effective daily dose in adults is 75 mg. Tricyclic antidepressants should not be used to treat depression in children and adolescents. For the SSRI fluoxetine, the starting dose is 20 mg in the morning, which is sufficient to obtain a satisfactory response in most cases. If there is insufficient clinical response after 6 weeks, the dose can be increased to 40 mg once daily in the morning. Side effects of tricyclic antidepressants include sedation, hypotension, blurred vision, difficulty urinating, nausea, weight gain, sexual dysfunction, QT prolongation, and arrhythmia. Side effects of SSRIs include sedation, insomnia, headache, dizziness, gastrointestinal disturbances, sexual dysfunction, and low sodium levels. There are no drug interactions between amitriptyline and fluoxetine and commonly used first-line antiretrovirals. Although amitriptyline and fluoxetine drug levels are increased when co-administered with boosted protease inhibitors, no dose adjustment of the antidepressant is required. Note that amitriptyline should be used with caution with boosted protease inhibitors because of the risk of QT prolongation, and ECG monitoring is recommended. Who needs consultation with or referral to an experienced provider? Consultation with or referral to an experienced provider should be considered as needed in the management of the depressed patient if there are signs of mania or bipolar disorder, or in the event of non-responsiveness to treatment, or drug side effects. Immediate referral is needed if there is a risk of self-harm or suicide. Asthma, chronic obstructive pulmonary disease, and HIV. Chronic obstructive pulmonary disease is characterized by persistent respiratory symptoms and chronic airflow limitation that is due to airway and/or alveolar abnormalities, usually caused by significant exposure to noxious particles or gases. Asthma is a chronic inflammatory disorder of the airways that causes recurrent episodes of wheezing, breathlessness, chest tightness, and cough, particularly at night and in the early morning. These symptoms are typically reversible and responsive to bronchodilator therapy. Pulmonary disease remains a primary source of morbidity and mortality in people with HIV, although the advent of potent combination antiretroviral therapy has resulted in a shift from predominantly infectious to more non-infectious pulmonary complications. People with HIV are at a higher risk for COPD, asthma, pulmonary hypertension, and lung cancer compared to HIV-negative individuals. The prevalence of COPD in people with HIV varies by study and by definition, but using spirometry, 7 to 9% of people with HIV have clinical obstruction, while 1/3 have respiratory symptoms. The US-based Lung HIV Consortium reported that among individuals with HIV, spirometry revealed 27% had obstructed airflow patterns and 10% had restricted airflow patterns. Incidence of lung cancer is 2.7 times higher in people with HIV than in the general population. Risk factors for lung cancers among people with HIV include aging, tobacco use, prior lung infections, and the inflammation caused by HIV itself. Signs and symptoms that favor a diagnosis of asthma are wheezing, a history of allergies, intermittent symptoms that are often worse at night or in the early morning, symptoms triggered by exercise or by changes in weather, and response to or alleviation by salbutamol. Physical examination may be normal between episodes, or there may be a wheeze, bronchi, prolonged expiration, and a raised respiratory rate. Symptoms and signs that favor a diagnosis of COPD are a history of tobacco smoking, exposure to indoor or outdoor pollution, slowly worsening symptoms that are persistent with little day-to-day variation, sputum production, and rhonchi. On examination, there may be just wheezing, diffusely decreased breath sounds, hyperresonance on percussion, prolonged expiration, and coarse crackles. In both conditions, a chest X-ray is usually normal, but there may be hyperinflation in the presence of severe disease. Drugs listed in the WHO Essential Medicines list for the treatment of asthma and COPD are inhaled salbutamol and beclomethasone, inhaled ipratropium bromide, prednisolone, and theophylline. Inhaled salbutamol is taken as 2 puffs as required up to 4 times per day. It may cause a tremor. Inhaled beclomethasone is taken at 100 to 400 micrograms or 1 to 2 puffs twice daily, and side effects include pharyngitis and oral candida. Inhaled ipratropium bromide is taken as 2 puffs 4 times a day. Side effects include bronchospasm, increased intraocular pressure, and urinary retention. The dose of oral prednisolone should be individualized based on the severity of asthma and the response of the patient. WHO recommends a typical dose of 30 to 40 milligrams per day. Multi-organ side effects are possible, particularly with prolonged use, including fluid retention, osteoporosis, and Cushing's syndrome. Theophylline is taken orally at a dose of 2 to 4 milligrams per day, and side effects include nausea and tremors. In many settings, however, the use of theophylline in asthma and/or COPD has largely been supplanted by other inhaled medicines on this list. There are no drug interactions between inhaled salbutamol, beclomethasone, or ipratropium and any first and second-line antiretrovirals. Drug levels of prednisolone may be increased or decreased with some antiretrovirals, but no dose adjustment of prednisolone is required, and drug levels of antiretrovirals are not affected. Finally, theophylline levels are decreased in the presence of boosted protease inhibitors, and a dose increase of the theophylline may be required. Consultation and/or referral to an experienced provider should be considered if the diagnosis is uncertain, symptoms are poorly controlled despite intervention, or regular oral steroids are required to control symptoms. Urgent referral is needed if there is acute respiratory distress or status asthmaticus. The final section of this module addresses cervical cancer. Cervical cancer is one of the leading causes of cancer death in women. Women and adolescent girls living with HIV are at an elevated risk for cervical cancer. The primary cause of cervical precancer and cancer is persistent infection with one or more of the high-risk or oncogenic types of human papillomavirus, HPV. In most women and men who become infected with HPV, infection resolves spontaneously. A minority of HPV infections persist in women, and this may lead to cervical precancer, which, if not treated, may progress to cancer. Cervical intraepithelial neoplasia, CIN, is a pre-malignant lesion that may exist at any one of three stages: CIN1, CIN2, or CIN3. If left untreated, CIN2 or CIN3, collectively referred to as CIN2+, can progress to cervical cancer. Women and girls living with HIV are more likely to develop persistent HPV infections at an earlier age and to develop cancer sooner, up to 10 years earlier than HIV-negative women and girls, and more frequently present with advanced disease. It is estimated that approximately 1 to 2% of women have CIN2+ each year. In women living with HIV, however, the reported rate of CIN2+ is 10%. Cervical cancer is an AIDS-defining illness. Screening for cervical precancer and cancer should be performed in women and girls who have initiated sexual activity as soon as the woman or girl has tested positive for HIV, regardless of age. In women living with HIV or of unknown HIV status, in areas with high endemic HIV infection, the interval for repeat screening should be within 3 years. Women who have received treatment should receive post-treatment follow-up screening at 1 year. In resource-limited settings, a screen and treat or see and treat approach is recommended. There is more information about this approach in the next slide. There are 3 different types of screening tests. 1. Visual inspection with acetic acid, or VIA. VIA is the WHO preferred strategy in resource-limited settings. 2. Conventional cytology, the PAP test. 3. HPV testing for high-risk HPV subtypes. The standard practice is to sequentially screen women using cytology, the PAP test. When cytology results are positive, the classification of CIN is based upon subsequent colposcopy with biopsy of suspicious lesions. Treatment is only provided when CIN2+ has been confirmed by histology. In resource-limited settings, the screen and treat or see and treat approach utilizes VIA screening followed by immediate treatment at the same visit or as soon as is possible. Recommended treatments for the see and treat approach are cryotherapy and the LEAP or LETS procedures. We will talk more about treatment options later in this section. Available treatments include 1. Cryotherapy. 2. The LEAP or LETS procedure. This stands for Loop Electrosurgical Excision Procedure, or Large Loop Excision of the Transformation Zone. And 3. Cold Knife Conization, CKC. Conization is not recommended in a screen and treat approach. In the absence of studies on the treatment of cervical cancer in women living with HIV, management is based on international and national guidelines for HIV-negative women. The cervix is the lower third of the uterus. The lower part of the cervix, the ectocervix, lies within the vagina and is visible with a speculum. The upper 2/3 of the cervix, the endocervix, lies above the vagina and is not visible. Most cervical cancers originate in the transformation zone, the area where the endocervix and the ectocervix join. VIA is performed by a trained healthcare provider who applies acetic acid solution to the cervix and visually inspects the transformation zone of the cervix to see if any white changes appear, which are indicative of abnormal cellular changes. In most instances, the VIA-positive woman can be treated at the same visit with cryotherapy to ablate the transformation zone. Both VIA and cryotherapy can be conducted in the field. thus eliminating the need for a clinic visit altogether. In women and girls who screen positive, cryotherapy is indicated if the entire aceto-white lesion and squamocolumnar junction are visible, and the lesion does not cover more than 3/4 of the ectocervix. The procedure involves applying a highly cooled metal disc or cryoprobe to the cervix and is performed without anesthesia. For screen-positive women and girls in whom the lesion extends beyond the cryoprobe or into the endocervical canal, the loop electrosurgical excision procedure is indicated. LEAP is the removal of abnormal areas from the cervix using a loop made of thin wire powered by an electrosurgical unit. The loop tool cuts and coagulates at the same time, and this is followed by use of a ball electrode to complete the coagulation. LEAP aims to remove the lesion and the entire transformation zone. The procedure is performed under local anesthesia on an outpatient basis. WHO recommends HPV vaccination for girls and boys in the age group of 9 to 13 years. For those not vaccinated earlier, HPV vaccine is recommended for all people with HIV, both men and women, up to age 26. People with HIV should also receive the 3-dose schedule at 0, 1 to 2, and 6 months. It is not necessary to screen for HPV infection or HIV infection prior to HPV vaccination. WHO needs consultation with or referral to an experienced provider. All HIV-positive women and adolescent girls, irrespective of age, should be referred for comprehensive screening and treatment with VIA, cryotherapy, or LEAP if the facility they are attending does not offer these services. All women and adolescent girls with signs or symptoms of cervical cancer should be immediately referred to a higher level of care. The primary sources of evidence used in the preparation of these protocols are guidelines produced by the World Health Organization for the management of non-communicable disease in settings with limited resources. For the most part, these WHO guidelines are not specific for people living with HIV and have been adapted as needed. This concludes the training module on the integrated management of HIV and non-communicable diseases. Thank you for your participation. You may now exit the presentation.